Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, and good evening, my dear vascular colleagues. I would like to speak today about the new European Society of Vascular Surgery 2023 guideline for antithrombosis. This is the most recent guideline. It's been issued in April 2023. It has a practice guidelines on antithrombotic therapy for vascular diseases. It will include carotid, peripheral arterial, aortic aneurysm, and also venous. It wouldn't change over the next couple of years. So definitely we are going to refer to this guideline over the next at least a couple of years. There is major changes in the medication of vascular diseases, and that is why it is extremely important to read this 69 pages document. If you want to download the document, you just scan this QR code and you can download the 69 pages. They are all very important and very enjoyable to read, but I thought to put it on a practical terms to get a summary of what is the minimum that a vascular surgeon going to an exam, going to career, and performing daily vascular practice, what is the minimum that we should grasp from this document. The QR code, you can download the document and you can read it, but I will try to summarize it little by little. There are multiple guidelines. As we know, I call them the Big Seven. These are the CDC, the International Society of Thrombosis Hemostasis, the American Society of Hematology, the American College of Chest Physicians, the Scientific and Standardization Committee of ISTH, and the Anticoagulation Forum, and the American College of Cardiology. You don't need to read all of them. The one which is very near to my heart is the American Society of Hematology, because they see what the cardiologist and vascular surgeon are doing from their paper, and they get really quite a sensible guideline in the middle. But with this new guideline, you don't need to read any of these seven. You go to the ESVS. The basics of any guideline, you must need to know two things. The recommendation, what is the class of recommendations, it has been changed, and the level of evidence. So for example, if I say class of recommendation 1, level of evidence A, this is the best way, you can be sure that this is a well-recommended guidelines. If it is class 3, it is not recommended to do. Now, we all now classify the guideline 2 into 2A and 2B. 2A can be, should be considered, 2B can be considered. So it's very important to know the language and the color coding as well. So class A recommendation is always green, class 3 is always red, and here is the yellow, light yellow and dark yellow for the class 2. Now the level of evidence is A, B, C, and it hasn't been changed. So this is the language we are going to use. Now, the first recommendation, before you give any antiplatelet to any patient, you must have a way of assessing the bleeding risk, which is called bleeding risk assessment. There is multiple systems to assess bleeding risk. Many of them are Americans, and some of them are European. The one which they advocated in this paper is actually came from German registry, and it's very nice. It's called OAC3 PAD, and this, as you can see, is classify the risk of patient into 4 categories. You either low risk or low to moderate risk, which is 1 to 4, or moderate to high risk, which is 5 to 9, or a high risk, which is above 10 up to 33. And they have developed this schedule of 5 elements. Each one of them you get a score. This depends on oral anticoagulation, on your age, if it is above 80 or below 80, chronic limb-threatening ischemia, heart failure, prior bleeding, and kidney. So it's very important to know the score of your patient before you prescribe. Is he a high risk or low risk, or is he low to moderate or moderate to high? It's important to classify into these 4 categories. And this is grade 1A recommendation. So this is very important. The second recommendation, the third recommendation, recommendation 3, if patient is taking antithrombotic with a history of upper GI, we know that PPI play an important role. This is now, it's a 2A, should be given. Level of evidence C, there's a lot of consensus, but if you have anyone patient with peptic ulcer, please prescribe proton pump inhibitor to these patients. And again, this is quite universal and has been changed. Now, the first part of the document, they speak about the carotid, atherosclerotic carotid artery disease, and they classify the carotid into 6 categories. I will summarize them quickly. The first category is early initiation of antiplatelet following symptom. If patients start to have symptom, what antiplatelet you need to give. The second is the dual antiplatelet therapy for patient not going into an intervention. Number 3, antiplatelet therapy for carotid endarterectomy, and the antiplatelet therapy for carotid artery stenting. So these are the first 4. The other 2 categories are antiplatelet to prevent the future stroke to carotid patients, cerebral and cardiovascular. And the last one is anticoagulation for atherosclerotic carotid disease. And let us finish number 6 quickly. There is no indication for anticoagulation to atherosclerotic carotid artery disease. There is one paper in favor, one paper against. The wave paper was against, a lot of bleeding, and another paper came in favor of anticoagulation, rivaroxaban plus aspirin, but at the moment there is no recommendation to give anticoagulation. So please don't give anticoagulant to carotid patient until we get an obvious clear guidelines. What are the antithrombotic agent to speak about? This is a very common question in the exam. There are 2 groups here, antiplatelets or anticoagulants. And what types of antiplatelets do you know? Again, very common MRCS exam. So you must know what the types of antiplatelets. They are basically either cyclooxygenase inhibitors, which is aspirin, and this is divided into low dose and high dose. High dose is above 500 milligram. And there is trifluzel, which is not found in abundance in Egypt, but this is the other cyclooxygenase inhibitors. The second class is ADP receptor inhibitors, which include either thiopyridine, like ticlopidine, clopidogrel, and basogrel, or non-thiopyridine, like ticagrelol and canagrelol. So this is the second class. The third class is phosphodiesterase, which includes celestazole and dipyridamole. So these are the 3 groups of antiplatelets. There is a 4th group, which is intravenous, but there is no indication for carotid artery disease to use intravenous like 2,3 GBA inhibitors. So very important to know the types of antiplatelets, and these are the 4 types that you need to know by heart. The intravenous, like abixamab and tirofiban and ibitfabine. These are the intravenous group of antiplatelets, strong antiplatelets, usually for coronary indication. Now, what are the option of antiplatelet do you have? Easy. You have 3 things, either single or double or triple antiplatelet therapy. So single antiplatelet therapy, you can use either aspirin alone. If he's allergic to aspirin, use clopidogrel. If he's allergic to clopidogrel, use pyridamole. All of them can be given in single dose. what is a double antiplatelet? Double antiplatelet therapy is 3 combination: aspirin clopidogrel, or aspirin dipyridamole, or aspirin ticagrelor. And the last one is triple antiplatelet therapy. And again, there is no indication for triple antiplatelet therapy in atherosclerotic carotid artery disease. And this is very important. Never to use triple antiplatelet therapy to any carotid artery disease. Now let us go to them little by little. I will just enumerate the guideline. So this is the minimum that you need to know. And then I will have one page, one image, that hopefully this image will summarize everything. So if you are asymptomatic with carotid artery disease, more than 50% stenosis, then the recommendation is aspirin between 75 to 325. We don't know what is the best dose, but this is the range of low dose that will reduce the risk of secondary cardiovascular disease. Class 1, level of evidence B. So this is number 1 recommendation. Now, recommendation number 7, asymptomatic atherosclerotic carotid artery disease, not going to intervention. So if you have more than 50% stenosis, you're not going to intervention, then you use aspirin and clopidogrel, which is double antiplatelet therapy. Patients who are allergic to aspirin should be offered clopidogrel to reduce the risk of secondary. If you are allergic to both aspirin and the clopidogrel, then pyridamole should be given. So it's a single antiplatelet therapy. Any of the 3. If you are allergic to one, you go to second, and this is 2A level of evidence C. Now, for the first and second group, patient with trans-ischemic attack or minor ischemic stroke with any degree of carotid artery stenosis is undergoing carotid endarterectomy or stenting are recommended to have dual antiplatelet therapy, which is aspirin clopidogrel, aspirin low dose clopidogrel for 21 days, followed by clopidogrel 75 milligram, or long-term aspirin plus dipyridamole to reduce the risk of stroke. So this is the recommendation for the first and second group. Again, patient intolerant or allergic to clopidogrel with trans-ischemic attack or minor ischemic stroke with any degree of carotid artery stenosis, not undergoing carotid endarterectomy or stenting, should be considered for dual antiplatelet therapy with aspirin and ticagrelor, which is the third category that we said of double antiplatelet therapy, or aspirin and dipyridamole, which is the second option. All these are alternative to anyone allergic to aspirin and clopidogrel. Class of recommendation 2A, level of evidence B. Now, regarding number 3, patient undergoing carotid endarterectomy, it's recommended to have antiplatelet before the procedure and perioperative period and over a long period of time. Here is recommendation number 11, which is important. Now, recently asymptomatic patient who are to undergo carotid endarterectomy should be considered for dual antiplatelet therapy with aspirin and clopidogrel postoperative to reduce recurrent stroke. This is the recommendation number 13 for patient going to carotid endarterectomy. Again, recommendation 14, recently symptomatic patient undergoing carotid endarterectomy for whom antiplatelet monotherapy is preferred should be considered for aspirin for 14 days followed by low dose to reduce the recurrent stroke. So you can see here just a single antiplatelet monotherapy. This is very important. Now the scenario number 4, which is carotid artery stenting because of the complication of embolization. Here they recommend dual antiplatelet therapy. Class 1, very strong, level of evidence C, which is just the consensus. Now, patients undergo carotid artery stenting are recommended to have dual antiplatelet therapy with aspirin and clopidogrel continued for at least 4 weeks after carotid artery stenting, because we know the stroke rate is always being mentioned with 30-day post-stenting. So even up to stenting for 1 month, you still can get a stroke. So double antiplatelet is recommended. Now, recommendation for scenario number 5, patient with ischemic cerebral event both undergoing and not undergoing carotid intervention are not recommended to have dual antiplatelet therapy with aspirin clopidogrel. This is very important because this group of patients have very high bleeding risk. So class 3, don't give it, and very strong evidence of A. And these are the papers that will reinforce this recommendation. Now, 6, as we said, no anticoagulation to any associated carotid disease. Some papers showed more bleeding, like the WAVE trial. Some papers show advantage, like the COMPASS trial, with rivaroxaban, low dose plus aspirin, but there is no recommendation. So please don't give anticoagulant to carotid artery disease. If the patient have bleeding, you don't have cover of any guideline you mentioned that you can give it. This is important. Now, let us summarize everything with the carotid in 1 page. And I will try to give you these pages, give you a very good summary of what you need to know in just 1 page. So let us go here into this page in PDF. So, patient with carotid artery stenosis. Number 1, perform a bleeding risk assessment. We said we are going to use the German score of OAC 3 PAD, which divide into 4 groups. Secondly, if you have patient, includes the use of proton pump inhibitor with a history of upper GIT tract. So if you have any upper GIT tract of bleeding, peptic ulcer, stress, then you should give PPI. Now you have to classify into 2 things. Either you are asymptomatic with more than 50% stenosis, or you are symptomatic. And if you are symptomatic, you're either going for intervention or not going to intervention. So here is the recommendation. And notice here, I'll just go quickly, the class of recommendation. In green is recommended. 2A should be considered. So, and notice the language should be. 2B may be considered. 3 never to give. So here is only 1 in red, and the rest is between green and blue. So we'll go quickly. So if you are asymptomatic, we said we're going to use aspirin, and this is very strong evidence. And if undergoing intervention, again, aspirin therapy should be used before, during, and after, with very strong evidence. So single monotherapy, if you are asymptomatic, more than 50%. If you are symptomatic, either you're going for intervention, which either carotid endarterectomy or carotid artery stenting. If you are going for carotid endarterectomy, then aspirin and clopidogrel for 21 days. If you are going for carotid artery stenting, then aspirin and clopidogrel 3 days before, and you can give 300 milligram loading dose of clopidogrel, which is 6 tablets. You give it at once. And to de-escalate double antiplatelet therapy, clopidogrel and aspirin plus modified release of dipyridamole from there. So you try to de-escalate, which is decrease the dose you are giving to these patients according to the risk stratification. If he developed peptic ulcer post-stenting, you need to de-escalate the double antiplatelet therapy according to situation. Do not continue dual antiplatelet therapy long term. So this is quite clear not to do. And let us go here for the patient not going to intervention. Then you need aspirin
aspirin 75 to 300, low dose aspirin and clopidogrel, double antiplatelet therapy for 21 days, following by clopidogrel or aspirin as a single therapy, or pyridamole as a single therapy. So you start by double antiplatelet therapy for 21 days, and then you followed by a single antiplatelet therapy. I hope with this summary that I am able to cover an important talk about the carotid indication, basically single antiplatelet therapy if you're asymptomatic, more than 50% stenosis carotid. If you're asymptomatic, mostly a double antiplatelet therapy, but it varies which one for how long. And you don't need to actually memorize it exactly, but you can memorize the page. Just a single page will give you the summary of this disease. I hope it is of benefit to you. I wish you all the best and see you with the next section of ESVS 2023.